Okay, we'll start the recording. Now, you see anything? Becky, your webcam is off. I've turned mine off.
Mine is off.
Okay. Do you want to stop the video feed for all participants? Video feeds? No. So, Barney, what could be the problem with not being able to see my slides?
I don't know. According to what it's saying on our screen is waiting for presenter to share the screen.
Okay. Which button do I use to share the screen?
I have no idea.
I've pushed every button. Oh, here you go. Select items to share. How's that? Try this. How's that?
It says there.
I have them.
You got them now?
Yes. Awesome.
Okay, you got the slides, right? Okay. Like I said, I'm going to show a little interspersed here, some information. It'll kind of keep you interested, but it'll, again, go back to some of the people you'll see on the hill or will come through first aid. I saw a little bit of this earlier, and it's really unnerving. Can you all see this?
I'm seeing it, Bob.
Yeah, Bob,
it's pretty ugly. This is why you need to ski under control. Okay, that's enough for right now. I'll come back to it a little bit later to keep you busy. Just going through these slides here for section 1. This is some basic anatomy stuff. I don't want to get wrapped around the axle because you can read this stuff in the file in your chapter 20 as well as I can show it to you the slides. The chapter does a very good job of getting into the nitty-gritty of bones, cartilage, joints, muscles, synovium, all this other stuff, types of injuries, how things heal, what's the difference between a sprain and a strain, and so on. And those are kind of the objectives. So in any chapter that you go through the objectives first, and then they will direct you through the chapter on what they want you to get out of it. Well, I won't go into the scenario here, but again, the things that control movement and so on, the bones are for your skeleton, and the joints are for making motion, and the muscles are what able to you to move your skeleton, and I won't get wrapped around that. The upper body, part of the body, skull vertebrae, and the thoracic chains, that's what gets you moving forward, upright position, and the arms, legs, and so on for your pelvis and legs. That gets you to move. Okay, so you got axial skeleton, and you got a appendicular skeleton. Boring, but stuff you need to know. Types of bones: long, flat, irregular, so on. Know your anatomy: the clavicle, the humerus, the pelvis, the ribs, the sternum, and so on. The different bones and where they are. That is important when you're doing your assessment. Self-explanatory. You got different types of joints. Free movable, the one in your hip, the slightly movable in your spine, and your sacroiliac joint in your pelvis. Again, the one thing I'd ask you to take away from here is that ligaments connect bone to bone, and tendons connect muscle to bone. That's about all you need to know off of this slide. Again, torn ligament is the joint that came apart from one bone to another. Tendons, muscles, the bones. And again, you can stretch or tear a ligament or a tendon. You can't see that, but that's what happens under the skin around the bones and the muscles. Different types of muscles. Some of the questions on your 80-question test talk about the different types. Again, you need to look at this rather than me just read it to you. Again, the healing process is affected by, how much damage there is, how old the person is, what their nutritional habits are. There needs to be guarded muscles and tendons while they're healing because they don't go very fast. You can injure them quickly, but they don't recover very fast. Cartilages don't heal, which is critical, and it's often that's when you have to have surgery. I'll show you my x-rays when I see you all up there. I've got 4 vertebrae that just got fused together. Looks pretty cool. Again, sprains, tearing and stretching of ligaments. Strains, again, overexertion, hyperextension, maybe minor to severe. Again, you strain a muscle or tendon and sprain is a ligament. Tendons, ruptures, fractures, you'll see a lot. Not a lot, but you'll when you do your assessments, you may come up and see that there's a fracture, but they're going to ask you, is it broke?
Kurt.
You can't tell them, okay, thanks, welcome aboard. You can't tell somebody that you have a fracture or not because you don't have x-ray vision. You just need to make sure they get down to definitive care and have an x-ray taken. But again, fracture is pretty basic. It's a break, but there are different types. And there are different internal, external bleeding and so on. Again, the chapter covers those really good. They have some good pictures. Look at the little captions on all the pictures because they are informative and they are educational. We talk a little bit here about internal bleeding. We'll talk a little bit more, and you'll notice why a femur fracture is significant because of the possible blood loss. But again, with any kind of a break, it could be blood involved. It could be soft tissue. It could be nerve. But I can guarantee you there's probably going to be some pain. Dislocations, multiple fractures. Again, I don't want to belabor this. Different types of fractures, but again, you're not going to know what type this is. You may have an idea, but only by definitive care with an x-ray are they going to be able to tell. The doctor will say what kind of fracture it is. As far as you're concerned, it's broke, it's broke. Different types. Could be open or closed, though there'll be significant ones. We'll talk a little bit more about the types of fractures later on. Good examples in there on the different types of fractures. The one you may see is this one right here. Excuse me, the third one from the left, green stick. Those are mostly in kids. Their bone growth plates haven't fully developed yet, so they don't have a clean break. They may have, it's like you take a twig and it's not a dead wood and you twist it and it just kind of splinters, but it doesn't break. It's called green stick. The older you are, and again, depending on your calcium, the more susceptible you may be to fractures. Talked a little bit about the blood loss. Again, you can see the pelvis, 13 to 1,500 milliliters. Significant amount of blood loss for a pelvis fracture. Femur is also. Any kind of blood loss, internal, external, is not good, and we'll talk more about how to handle that. But just gives you an idea of where the bone and the blood loss might be. That's all I'm going to cover there. I'm not going to get carried away with that. A little bit more fun here, if you'll bear with me. Some of these are pretty scary. Whoa, where'd he go? Don't know what happened there. Stand by. All right, come on. This is working good before. We don't have any mountains this high, luckily, or we probably have people going off them. Yeah, that's what I'd say. Woo.
I would venture a guess while Bob is doing this that Barney and Bob could probably go through insane ski accidents on YouTube and probably over the years has seen every one of them.
Some of them I wish I hadn't seen, but yeah.
Yeah, some you wish you hadn't seen.
Okay, we'll come back to this a little bit later. Let's go back to do another section of these PowerPoints. That was section 1 that we just did. Section 2 is assessing. So somebody comes in and you see them on the hill. Again, these are slides I won't spend a lot of time on, but again, all this information is covered in that chapter 20. It's a very good chapter. Let me close this guy down. He'll keep falling for a while. Sorry about that. Okay, chapter 20, this is the assessment. If you look in your chapter 20, there's 3 parts. The one's the physiology and anatomy, the assessment, and the last one we'll cover is the management. Management. But again, talking about MS, it's the musculoskeletal injuries. General assessment, signs, symptoms. The chapter is very good, and I can guarantee you that we're going to cover this ad nauseum on the 22nd, 23rd, 24th, whatever that weekend is. We'll get a lot of hands-on. This is the part of the knowledge part that you need to be doing on your own, because when you come up to the hill, it's going to be demonstration performance. The knowledge should be in place, and we're just going to kind of dig it out, refresh it, and put a lot of hands-on. Most of it's going to be hands-on. No slide presentations or anything. So that'll be good. Again, you're going to start assessing a patient as soon as they walk in the door. It could be the way they're limping. It could be the way they're holding their hand, whatever it is. But you're going to get an initial impression. When they walk in or you go up to them on the hill, they're going to give you some idea of what the, let's say, injury would probably be. Talked about ABCs, the sample, the vitals. Basically, you're the most important person in an accident. The second one is your buddy, your other patroller, and the third one is the patient. Again, determine the number of patients, 1, 2, 5. Maybe they were leaning against wrapped around a tree, or look for guarding. Maybe they're holding their hand up close to their chest. Give you a lot of insight by looking at the scene and the patient. Again, very good assessment chart here. DCAP, BTLS, anything that looks out of the ordinary. Pain, tenderness, deformity. The good thing that when we were created, she did it the right way because they gave us 2. One you can compare against the other. So look at one shoulder, look at the other shoulder. Look at one hand, look at the other hand. See if there's symmetry or there's some deformity that you can recognize a little bit more clearly. You know, as Becky, I said she. You're welcome. Okay. Assessing CMS, circulation, motor, sensory, distal to the injury. Do that before you treat, during your treat, depending on what you're doing, and when you're finished treating. You want to make sure that if there is any change that you didn't cause it, or if there is one that you do note it. Talks about when you palpate, expose, figure out what you're going to do. Again, always reassess vitals, and that CMS is ongoing. If you don't know what else to do, yeah, go ahead.
You know, another important in terms of assessment, because I know when I first started, this is Becky, you heard the word sample, you heard decap bottles. I cannot impress upon you enough, know those acronyms, know what each of those letters stands for. For example, in decap bottles, what does the D stand for? Who knows the answer to that one?
Deformity.
Deformity, right. So again, yeah, as you go through these slides and as you go through your learning, chapter 20 is critical. And know your acronyms, because you will see them on the test and you will use them in assessment on the Hill. That's all I was going to say.
Yeah, Becky's got a good point there, is that you need to start getting into not rote memorization, but getting used to doing your assessments, your vital signs, your treatment the same way all the time. Okay, it can be different by the patient, but you know, you always check CMS, you always check the site. You do your initial assessment, you do a secondary assessment, and so on. We'll talk a little bit more about the sample and so on, but those are things you just need to kind of do without thinking. It needs to be ingrained into doing it. And I would tell you, just looking at like chapter 20, except for altitude, sickness, asthma, probably at least 60 to 70% of your patients are going to come under chapter 20. Okay, pressing on here. Again, look around, see who you've got. They'll talk a little bit later. I won't get into the minutia now about making reports or so on, but again, figure out what you've got, figure out what you need, and figure out what you're going to do. We'll talk more about that over the weekend. What is it? What are the problems? These are the things that you normally see. You know, and this is where you get into the DCAP BTLS of one side doesn't look like the other, or there's bruising. It shouldn't be bruising. They have pain. They shouldn't have pain. Crepitus is that grinding, crunchy feeling. They shouldn't have that. So anything that's out of the ordinary, something that just catches your eye, is something that's going to be a sign or symptom. You know, a sign is what you see. A symptom is what they tell you. That's important to remember. But you need to question them, and we'll talk more about assessments and everything later. But again, these are signs and symptoms that you're going to see just about any time you see somebody on the hill, when they call for help, or when they come in first aid on the sleds. Pretty good here. You can see the differences between the two shoulders here. For this individual right here, the bottom picture, this shoulder on the left, of course it doesn't work right now, but oops, let me go back. This right here doesn't look right. So you go, I don't know if that's supposed to be that way or not. So you go over here and take a look at the other shoulders. No, that looks okay compared to this one. So now you know there is a difference. Sometimes they've had a fractured collarbone, and they may have had it fractured on both sides, or it may be a deformity just the way their collarbone is. But again, you need to talk to the patient, get the information from them. Skin upper extremity injuries, and we'll play a lot with those. You'll go through just about every one you could find when we get up there on the weekend. Snowboarders do a lot. Scapulars are very hard to fracture. That's a tough one to break. That's behind your back. Clavicle, a lot for snowboarders. Shoulders, a lot of times that folks have a dislocated shoulder. They have a tendency more to easily dislocate that in the future. But again, there's the elbow joint, the wrist, the radius, all in the hand, fingers. Anything is susceptible to injury when you're out there on the hill and either get hit by somebody or you hit something that doesn't move. Like I said, clavicle fracture a lot. You have dislocations. Again, scapular fracture, it's mechanism of injury had to be pretty significant for someone to fracture their scapula. That's one I have not seen. Again, humerus fractures like the bottom one there about the nerve damage. Any kind of fracture could have an impact on their nerves. So that's why you have that circulation motor and sensation. CMS, check it all the time. Again, the bottom line, all this, you can skip to the last line. I looked at this. It says the position in which a patient holds the injured arm can help you identify a possible injury. You're going to see that when they walk in, when they come pulling up on the sled, sitting up or laying down, or sitting on a hill under a tree. They're holding their leg, they're holding their neck, they're holding their arm, shoulder, whatever. That'll give you an initial clue of what you're going to be treating or might find. Basically, you can fracture anything you want. It's oversimplified. The skier's thumb, another name they have for that, which I thought was interesting, because they have sometimes they have their ski poles on with a strap around their hand, and they break their thumb. It's also called a gamekeeper's thumb. Gee whiz information. But again, usually they have their ski pole around their hand, and they hyperextend their thumb, and that's what causes that ligament problem. Different types of fractures. Some of them may not be very obvious. Some of them may be very obvious. If you see one like this, or a break just above the wrist, called a Collins fracture, it'll be deformed, and they'll say, is it broke? You don't know for sure, but you're pretty sure they need to go see definitive care. You may have amputations too, which again, you would put that in a moist towel and secure it in a Ziploc or somehow, and have it go with the individual, either from the mountain down to first aid, or from first aid down to with EMS. Hand bones may fracture or dislocate. Gee, that's a hard statement to remember. Again, pelvis to toes, top to bottom, hips for femurs, joints, tib, foot, toes, joints, etc. Femur fractures, just like scapulas, going to be a high energy trauma. They've been going pretty fast or dropped a significant height to fracture a femur, or to be hit by somebody going at a high rate of speed. Those are significant. Lower extremities, again, we'll talk more about this when we are not getting into assessments. But again, pulse, motor, sensation. There's a couple of places you can take the pulse for the foot. Once you get the boot off, checking the pelvis for a pelvis problem, or the leg itself. One of the little tricks you could learn is that a lot of times somebody will say that it doesn't hurt when you palpate. But if you palpate and watch their eyes, they'll flinch, although they'll tell you it doesn't hurt. If they flinch, it hurts. Lower extremities, we'll talk about those, and we'll do more about that. Patellas could get knocked off of the little ridge that they run on. Tib-fib fractures, ankle sprains, any kind of foot injury could just happen any different way. I've had people come in that had their ski boots on the wrong feet, and were complaining of foot injury, which was pretty obvious. Knee ligament cartilage injuries are common. You'll see a lot of those. ACL, your ligaments and tendons around your knee is like an interstate. They have a lot of problems that you could go wrong in there. Lower extremities, again, just gives you a good idea of ski and boot stay in place. Spring-loaded bindings clamp, they don't let go. Knee tib-fib here, right above the boot, because the bone gave before the top of the boot did. Okay, took care of that one. We're making progress, folks. Any questions so far? Oh, this one here. Ripping his hips wide open. Boom, boom, boom. I saw that one. Look at that. You could tell. And I think right off there was one similar to that at the Olympics that the Ski Patrol showed up right after that. Okay, let's go back to the last one, which is really the important one I want to get to, section 3, the management. You've done you know your physiology, your anatomy. You've done your assessment. You figure out what you've done. Now, how are you going to take care of it? That's the management part. A couple of different things you could do, and we'll talk about these. Some of you may be familiar with them. Some of you haven't. Some are a lot easier to take care of. Others are harder. What I would tell you now, and anytime you do it, when you put a sling and swat or splint or whatever kind of a immobilization device on the patient, one of the key questions, if you only got one right out of the 80 out of the chapter 20, is There is no one way to stabilize an injury. It doesn't have to be pretty. It can be pretty, but it just has to be functional. I've seen them come in look really pretty and not exactly well done. I've seen others that look like you didn't know how they do it, but they were great. So again, how it looks is not as important as how it works. And you'll get a lot of practice with all these different splints. Again, this is what you're going to be doing most of the weekend. Again, BSI, you're the most important person. Always carry gloves in my pocket. You know, if you're thinking about it in first aid and you know you have a multi-trauma situation coming in, you can always put 3 pair of gloves on. Take care of a patient, take a pair of gloves off, and you already got a new clean pair on. But again, plan on what you're going to need for help. On the hill, basically, I would say what you do is you assess, stabilize, package, and transport. That's what you do. Assess, stabilize, package, and transport. You figure out what you need. You stabilize it by getting your help with people or equipment. You package them on the sled, sitting uphill, downhill, whatever it may be, and transport them to first aid. Same with first aid. You're doing the same thing, except instead of putting them on a sled, you may be putting them in an ambulance or putting them in their sponsor's car, whatever. But again, this is very, very basic, but you need to work about this. Expose the injuries, check, see what you got, control bleeding, bandage wounds. This is all very, very mundane. Should be common sense to you. Again, this immobilization, check CMS, circulation, motor, and sensory. Can you feel this? Can you move that? And check the pulse. Transport to aid room, monitor patient comfort. If you're on the hill and you bring a patient in, you'll give a response, a report, and to fill out the initial paperwork on what the patient happened, what you did on the hill, and brought them in, and then the people in first aid will take it from there. But again, reassess for CMS. O2 is needed, transfer to higher level care. We'll talk more about that later. Purpose of a splint. It's like a doctor, do no harm. Decrease movement of broken bones. It helps the clotting, prevents further blood loss, helps decrease the pain. Muscle spasms can be excruciating, particularly for lower leg injuries. And you don't want a closed fracture to become an open fracture. So again, splinting is key. It's critical. Yeah, I get this real fancy here. I don't usually do this. Where is it? Okay, well. Ooh, how about this, huh? Okay, so here we are here. Again, decreased movement, allow clotting, so on. Again, you're not going to always have everything you need readily at hand, even in first aid. You're going to have to use a little imagination, a little creativity. But again, some of the basic ones here that we'll play with and some that we'll also make up. You've got the head chocks, the backboards, the cardboard splints, the air splints, the SAM splints, and so on, and we'll play with all that stuff. Please try and make it up there. It will be well worth your while. I've got to drive 9 hours to get there, and I'll make sure that I make my drive worthwhile if you all show up. See how this here for tissue damage. You don't want to make anything worse. Again, it makes it easier to move the patient, particularly off the hill, of course. And you want to prevent any possible nerve damage or injury for spinal injuries, for instance. Again, we'll talk about all this stuff. This is a good actor here. She really looks like she's in pain. And these are, we'll do a lot about sling and floss. There's a couple of tricks that you probably can teach me or I can show you about what it's for and how to do it. But that's basically your everyday sling and swap that you're going to do. Again, it may be that the injury is so that you cannot straighten or do not want to straighten the arm. So again, here it looks like they're using a SAM splint to make a straight splint. You may use a pillow. You may use, if they're standing there in first aid, or, you know, it wouldn't be first aid, but, you know, use whatever their clothing that they're not using, for instance. You know, you could use their caps if they're in first aid for additional padding. But use whatever you need to pad that injury and to immobilize it so that you don't cause any further damage. You can see what they're doing right here, as we talked about before, these checking capillary refill. You can see this right here. It looks like she's got something in, or he's got something in the palm of his hand. We'll talk a little bit about more. That's like a roll of gauze that you'll give them to hold on to. And you'll see another picture. It's basically what they call position of function. It helps with not exacerbating the pain, and it doesn't impede recovery if they're going to be doing this for a while. We'll talk more about that. SAM splint, pelvic sling is very important. You'll learn how to use that. There's sometimes you use it and sometimes you don't. We'll talk about that. But it's a very good immobilization device. The rigid splints is whatever you can make. We use a lot of cardboard. Don't normally use wood. On the hill, and when they come in, they usually have a quick splint, which you'll see in just a minute. Depending on the injury, they may have to do an airplane splint or a metal splint called like a ice cream tongs, or traction splint. Traction splint is one that you should play with for sure, and that it's a very perishable skill. If you're not used to putting on a traction splint, you know the next patient you get is going to need a traction splint. So be very familiar with traction splints. This is one where you do a splint so that they can't straighten their knee. Maybe it's a knee injury. But again, be inventive. Immobilize above and below the joint. That's very important. Always immobilize above and below the joint. These are the cardboard splints. A lot of times, patients who cannot walk out of first aid but need to go down to Lincoln County Medical Center, we can give them just a makeshift splint to put on to replace the quick splint that you took off when they brought them down the hill. Very good, very rigid, and it works quite well. We'll play with those up there also. Again, you can make them different lengths, and you can even use them on the arms, but these are normally for the legs. Again, here he's or she is trying to figure out how they're going to do this, figure out the best way. It looks like it may be a knee injury here, and he's measuring this or she's measuring it to see how they're going to put it on. But again, figure out what you got and how you're going to best handle it. Remember, they got their gloves on. SAM splints are great. You can use them for C-collars. You can use them for just about anything. There's different ways to bend them to make them as strong as plaster Paris. You should carry one in your backpack. We're on the hillers, and they're always available in first aid.
Hey, Bob.
Here again. Yes,
Bob,
go ahead. Yeah, go ahead.
They should have a video I gave them the last time I was up that talks about the SAM splint. I urge them all to make sure they review that video before they come up next weekend.
Yes, please do. Glad you brought that up. I've got one myself here somewhere, but you'll be, man, this is pretty cool. I didn't know you could do this. It's very malleable, but however you form it, it's very, very strong. It's an exceptional tool that you should keep in your toolkit. And again, this is the traction splint. Again, I'm going to be playing with that first because it's been a while since I played with it. And it's like knowing CPR. You're going to have to use your CPR about 2 weeks before it expires. It's been that long since you looked at it. So for the people that stay in first aid to begin with, or whenever you have a chance and it's not busy in first aid, come and play. Practice your sling and squats. Practice traction spin. Practice your skills. I'm a paramedic here in San Antonio, and I would tell you, same for EMS up on the hill or a first responder, it's a very perishable skill. EMS, emergency medical science, if you will, is very perishable if you don't practice. Again, this is another one that you don't usually see. It's a traction splint. Depends on how you put it together. The first time you take a look at it, it's a pretty intimidating, but when all else fails, read the directions that are on it. Again, improvised splints. You may have to use it for a finger or whatever. Here you can see, for instance, this may be injury somewhere in here. And again, you see that position of function, you give them something to hold on to. And always ask the patient to help them if you can. You know, can you do this for me? Can you? Yeah, that really helps me a lot. Thank you. Okay, that's good. You're a big help. This is working really good. So try and get the patient involved in their own care when possible. When you wrap this, you'll notice that you're going to leave a little area clear where you can check cap refill up here, and you can also check a pulse here. You don't want to bind it all and look like a mummy, and then you don't know if you've insulted their CMS. Types of splints, you name it. You can use a pencil, you can use newspapers, whatever you have available. And I can almost guarantee you that whatever accident you come upon or whoever comes in, you're not going to have the exact thing that you need. You're going to have to modify whatever's available or just be creative. That's where I go. I go back to, it doesn't have to be pretty. It just has to work. Again, some obvious stuff here for on the hill or getting them off the bed. Splint them before moving them. Check CMS before and after. Stabilize the injury. Pad. Use the right type stabilization. Be very careful. Again, work quickly, but again, it's a sense of urgency. I don't know how you want to say it, controlled enthusiasm, but just go with a sense of urgency. Don't go faster than you can give adequate care. That's as fast as you should go. We'll talk a little bit more about lining, deformities, and so on. That's not normally done, but there are some options that they give you in the OEC manual, and we'll have to confirm what they are in first aid for the protocol. Again, secure it. If they can't straighten it, if they can't move it, if it causes too much pain, secure it in the best position of stability and comfort. Usually you'll see if somebody comes into first aid and if you can imagine they're holding their hand and they've got it up to their chest, that's basically how you're going to put a sling and swath on. The injury is going to be a little bit higher, a little bit closer to the body. So whether they know it or not, the way they hold it is usually a position of comfort, and that's why they're holding it there also for stability. Again, severely angulated, dislocated, the ones that just go, oh man, you're going to have to figure it out. If they don't let you move it, you can't move it. And if it's an injured for an impaled object, you're going to have to work around it. We'll play with those also. Again, you can see here they had a couple of board splints, used some pillows to rest it on, but again, above and below, probably a knee injury. You don't want to put one of these securing devices right over the injury. You always want to do it above and below the joint. Pretty obvious. You don't want to reduce a fracture. You don't want to try and make an open fracture a closed fracture. One of the questions on the test is, you know, if it's a hand problem, get their jewelry off before the swelling occurs and they have to cut it off or can't get it off themselves. Again, immobilize above and below the joint. Bones for joints, joints for bone injuries. It's just, that's one of the takeaways for here. And if you have any doubts as to what the injury may be, almost always advise them to seek follow-up care. Give them that to Lincoln County Medical, tell them what they need to do, where to go, and also document that. We'll talk about documentation another time. We'll do a lot of this, upper extremities, shoulders, clavicle, scapula, sling and swaths, figure eight, blanket rolls. We'll play with all this stuff. Posterior, anterior dislocations, and so on. Here he's trying to figure out what's going on, doing an assessment. Again, if the individual is not conscious or isn't responding to you verbally, as you do your palpations, perhaps you may want to watch his eyes to see if he winches or tries to make any movement. Upper extremity injuries, we'll talk about elbows, the sling and swath, stabilize, blah, blah, blah. And here it talks about one axle alignment if it's 2+ hours away, which is not at Ski Apache. Again, option to use malleable or rigid splints. Whatever you need to do to stabilize and protect that injured area. She is not happy. But you can see it's probably an elbow. But again, you stay away from the elbow. Kind of got a little sling on there if she could tolerate that. But the swath is not over the injured area, and there's no direct pressure right on the elbow joint itself. Again, this is exposed, so you can still check pulse, motor, and sensory skills. Again, straight. They can't move it, don't move it. This one here, they secure to the body. Haven't seen one of those done, but that may be an option up on the hill to get them on a backboard if it needs to be done. What I would tell you is, having been on the hill a lot of years, we'll talk about we'll do it when we get up there. We'll talk more about that then. Upper extremity injuries, forearms, blah, blah, blah. This goes on and on and on. You're going to be thinking about this stuff in your sleep next Saturday. We're going to cover this ad nauseum. Digits, you need a tongue depressor. You can use those. Make sure we secure, I think you've already done this, the impaled objects. And then the amputated parts, moist, sterile dressing, wrapped up and sent with the patient. That includes teeth. Again, here we go with that position of function again. And the injury area may be here. The ice cream tongs they talk about, you might have a SAM splint that comes down here and goes all the way around the top. Position of function. Caring for specific extremities, okay? Remember, he's got his gloves on. If I don't do it, I would do it to you. Becky, while you do that, let me do that for you while you put your gloves on. As opposed to saying, Becky, how come you don't have your gloves on? Okay. Always try and catch each other. Here again, a nice little splint, one finger to another. Could be the, put it on a depressor or whatever it might be. Here's a tongue depressor. Thought I'd seen that before. Lower extremities, we'll get to play with those also. I'm glad that Barney's going to be there. He's really good with that stuff. Backboards, C-collars, traction splints, and so on. Pelvic fractures, we talked about pelvic binder you saw earlier. We'll do those. We'll do the spine boards. Not sure we're going to do the vacuum splints or the double pole traction splints, but we'll see. Stabilize hip fractures, pad voids under knees. Anytime you put somebody on a backboard or anytime you're stabilizing, attempting to stabilize an injured area, don't leave any airway in there so that they can move around or might exacerbate the fracture or whatever. Just put the padding on there. It's almost like if you packed it in a pillow. You just want to make sure you don't compress it, but you want to stabilize it. We'll talk about femur fractures, traction splints. Those can be pretty painful to patients. That's the best way I can put it. Again, load and go on the hill. If it's massive trauma, just get them on a backboard and bring them on down best you can. Boot removal based on local protocols. We have refusals, or not refusals, but permission slips that patients have to sign for them to have us take off their boots. Fractures, we'll talk about, you don't need to put traction splints on distal fractures. It may keep it bent. However, it's best for comfort. Again, it's not 2.5 hours or 2+ hours, so we're not usually going to be doing alignment. This is one of those from before. Tib bib, combined femur, tibias. We'll cover all this stuff up there. Here's one of the air splints. I also can use that to control bleeding in addition to a fracture. Again, this is probably the injured area, someone here. You wouldn't put it over here if it was the injured here. You'd stabilize it here and here, above and below. Ankles, feet, toes, do what you can. It may be best not to take the boot off. They may want to leave it on. But that's something that you assess at the time. We can't take the boot off unless they give you permission.
Hey, can I ask you a question?
Sure.
With that air split, how do you check CMS?
You check it before.
And then you can't check it anymore.
Yeah.
I think, did it cover the whole toe, or is the toe sticking out?
It depends on the type you have. Some cover the whole thing. Some of them is like a sleeve on an arm. But
right.
Yeah, if you can't get in there, you can't get in there.
Okay.
Well, you can check tell them to move their toes so they get the movement and they feel their toes, sort of thing.
Okay, so you get the MS.
And if the color is white, you may have made it too much and put off the circulation. So,
right.
skin color, they can move, or whether they can feel their toes, you don't necessarily have to feel it.
Yeah, a lot of times when they come in, they bring them in, they put them on the bed, and you're asking what the problem is and so on. Can you move your toes? Or you can tap on their boot and see if they can feel that. But if you can't get in there to get a pulse, you just can't. But you always do for the traumas that come in on the back bed for trauma bed, and Fred likes to put a little X on the places where he finds the pulse. Makes it easier for EMS also. A good question. Okay, many quick splinted injuries are repackaged in the first aid area. Again, you may not want to change it at all, but maybe you had to get them off the hill in a hurry, and then they have to do a little bit better job in first aid. If they come in and it looks like it was well done and it's doing its job, there's, if it's not broke, don't fix it. Just dressing and bandage, I mean. But just tighten it up or fix it up, whatever you need to do. Again, consider not replacing it like it says here. If it's multiple injuries and they've been stabilized, it's a very unstable fracture. Maybe the best they could do is what they did on the hill, and you're not going to be able to do a lot better in first aid. This is one of the quick splints that they carry in the sleds that they'll put on a lower leg injury. And when they bring them into first aid, this is what we take off after we get some information from the patient, and then we start doing our assessment in first aid. And basically, once we get that off, we have to get permission to take the boot off. We'll do practicing with the boot removal and so on. But again, it's not a one-person job, and you do have to get their permission.
If it's a really bad leg injury, how often, or what's the percent that you can expect shock to sort of set in?
I would tell you without hesitation, anybody you bring into first aid is in shock.
Okay.
Okay.
I know if you break a leg badly and you damage nerves, I mean, you're probably going to go into shock, right?
Right, you are. Even a sprain or a strain.
Bad strain. But
yeah, it's different people in age, nutrition, what the injury is. And I wasn't being facetious, but to a certain degree, everybody is coming in, and their blood pressure is going to be up, their respiration is going to be up, their just anxious and so on. Some of it just may be natural to a certain degree, but other may be caused by the injury. But again, that's where you get information from the person who brought the person in, the patroller brought the person in, and then you monitor vital signs. That's real important. O2, right. Vital signs, and so on. You do those for an injury. It's every 5 minutes.
Right.
So somebody grabs a board and starts doing vital signs, and if you have enough people, if you're lucky enough, then one of them is just in charge of doing vitals every 5 minutes. That's a good question. Everybody, when that sled pulls up and everybody's running around like a chicken with their head cut off, the people in first aid are going to be in shock to a certain degree because everybody's hyped, okay? But, yeah, some of it is quasi-natural. And some of it, the shock is caused by the injury.
Right.
Here's that cardboard splint. That's a good question. There's that cardboard splint that you can put on if the individual can't walk. But again, if you're going to put this on them, you're also going to be having them go down to Lincoln County Memorial to see a doctor, get x-ray, and more definitive care. And again, you would pack this with the plastic wrap you see on your dry cleaning, to fill up all the voids and put some ice on it, so on, and send them on down the hill. Depending on the injury, pelvis fracture or whatever it might be, as soon as you know on the hill, you may call for transport. And people in first aid will call for an ambulance because it takes about 45 minutes to come up the hill. So as soon as you think you need transport, or first aid knows that they need transport, they're going to call it because you don't want to keep them in first aid any longer than possible. Ideally, by the time you get them packaged and come down, we do a little bit of paperwork and a little bit of make it pretty or treat it whatever needs to. EMS will be there really quick, which is what we want. Again, there's some controversy if you're from England about when to remove a boot. Usually don't take it off on the hill, and there will be some certain circumstances where you don't take it off in first aid. Usually they want it off because it helps your assessment. You help with the CMS, and you see if there's any injuries that you might have not seen. But there's a certain way that you need to take it off, and we'll practice taking the boots off. Also, we'll probably do some helmets too. Jams and pretzels. You're never going to see anybody laying there just like this. They're going to be like this, wrapped around a tree or a big boulder or whatever. And we'll practice getting people in the right position to log roll them, put them on a backboard or scoop stretcher or whatever it might be for movement. Different numbers. This is what you want to get them to. Position 1. You're usually going to be about 2.5, 3, 3.5, somewhere in here. You're going to have to move something to get them to supine, neutral, straight. Again, people on the hill, you'll call for patrollers, call for equipment. The person at the head is normally the one that's in charge, and he or she is going to be directing what everybody else do. I would tell you in a trauma situation, whether it's first aid or up on the hill, if there's more than one person, say for instance there's 2, I do this every time I have a chance. There's 3 questions you need to be able to answer. Who's in charge? What's the plan? And what's my job? Everybody needs to know who's in charge, what the plan is, and what they are specifically tasked to do. Otherwise, you'll have 2 people doing the same thing or somebody not doing something they should be doing. We'll talk more about that. But again, very carefully unjamming the pretzels, getting to position 1. So he's working together. He's probably he's probably directing him what to do, and he's controlling the head. Also, what would be good here is if on the hill is this individual is also talking to this individual, checking the level of consciousness, making sure they understand what's going on, because this person is in shock. Again, rolling them over. It doesn't have to be fast and sloppy. It has to be slowly controlled. Never drag them left and right. It's always on the horizontal plan, if you will, straight plane. axial vertical, never sideways. Short movements, and when I would say, when you tell somebody, the person at the head says, okay, we're going to move him up the backboard a little. A little means something different to everybody. We're going to move him up the backboard towards me 2 inches. And then the key to that is, if you say, is everybody ready, and only 4 of the 5 say yes, the 5th one may do some damage. So my warning to you is that, okay, we're going to move him 2 inches towards me up this backboard. Is anybody not ready? Those are the ones you want to hear from. If you don't hear anything, then you know everybody's ready. Again, this is pretty obvious, and we'll practice this. Secondary assessments. That was just the case that we had. 206 bones. The human being is very capable of breaking just about any of them. The bigger, the longer, the more important ones usually get broken just as well as the easy ones. It could be something from a finger, it could be to the pelvis. Talks about lower bone fracture is a disruption in the continuity of a bone. True. Dislocation is disruption in joints, splint. Soft, rigid devices, 4 basic types. So whatever you need to do, be creative to get that splint to be working. Sprained knees, ACLs, so on like that. Most frequent injury while snowboarding is distal radius fracture. Skier's thumb we talked a little bit about. Clavicle is the most commonly broken bone. Again, make sure to get all the jewelry off before the hand or foot swells too much, and they're going to have to cut it off or starts cutting off circulation. Treat life-threatening things first, and then manage those broken bones. Let's see. Let's do one more video here. We're right at about an hour. Well, this is a dead one. Probably not one you want to see, but we'll watch it anyway. That'll be enough. Again, some of those injuries you'll see off the terrain park or slipping in front of first aid, whatever it might be. Again, assess, stabilize, package, and transport, either off the hill into first aid or first aid down the hill. I covered all 3 of those PowerPoints. The first one was on musculoskeletal injuries, basically anatomy and physiology. The second one was on, this last one here was 3. That was on management. So there's a lot of information here. What I would ask you to do is to go through your chapter. And there are certain places, know, understand, and so on. They're kind of interim summaries. Answer those questions within the chapter. There's 5 or 6 different sections that if you can answer those questions, you got the gist of what the chapter was about. If you can't answer those questions, you missed some pretty good information before you got to those questions. So go back. If you don't take anything else out of those chapters, those 15 or 20 questions for the chapter are going to get you, they're going to pay big dividends for you. I've done the online portion of the, I don't know if you heard that, Barney, your in directions work. I did the online portion of the refresher, and there is chapter 20 information on there about musculoskeletal injuries. So it's not wasted information. You're going to need it when you show up at the end of September for the refresher. I have the answers to the 80 questions. I don't want to go into those right now. If you want to go over those, you can give me a call, 210-415-5958, or I will have the answers to the questions for Chapter 20 when we get up on the hill. But my goal, and Barney always does this, and I really admire him for it, my goal is to be smarter than anybody else that shows up there. I need to be more prepared than you are, because it's all very perishable skills if you don't use a lot. So I'm going to do my studying. Hopefully you all do yours, and it's really going to be educational. It's going to be fun, and you're really going to be able to practice a majority of the skills that you're going to use on the hill or in first aid. That's about an hour. Has anybody got anything? Barney, you want to add anything? Or Becky?
Yeah.
Or any of the candidates got questions? Please bring them up.
This is Barney. I just can't stop make sure.
You're breaking up, Barney.
Okay. Especially 20, I can almost guarantee the written exam will be covered after 20. All the we've done that. Starting out, the test is only way.
I'm not hearing Barney. Is everyone else hearing Barney?
Yeah, Barney, I think you're breaking up a little bit.
No, yeah, I'm not getting him either.
Yeah.
Someone was moving. Hello? Everybody can
Go ahead, Barney. Go ahead, it's a little bit better.
And all I just want to reiterate and emphasize to study the test bank questions. I'm pretty sure Chapter 20 will contain about 10% of the written things. So we see those test bank questions.
This is Becky. If you guys can hear me, and I will reiterate what Barney says. You better know Chapter 20. Many of the questions on the test will come from Chapter 20. In the back of each chapter, you have a skill guide for different skills, like splinting an upper extremity. Print those out, tear them out of the book, whatever you want to do. But when you're practicing your assessment and skill, use those as a guide. Something else you guys might want to consider if you're going to be at the mountain. In the evening, sometimes 4 or 5 of us would get together. We would have already answered our test bank questions, and then we just admittedly said, oh, I didn't get that one right, because you're not going to get the answers to them. So you have an opportunity to discuss the test bank questions as well. But look at the skill guides at the end of the chapters as well.
Yeah, the one PowerPoint I didn't cover in detail was the one about the skills, and I was going to finish up with that. Is that I've got there's about 50 scenarios that I've got 10 of them that we can use to play with, and also I've got the skill sheets that are in your book, but also we're going to be doing the skill sheets and the scenarios to practice. So on test day, whenever that is, it's not going to be anything new. But again, for this, in your book, there's about 14 skills. It talks about sling and swath, which I'm showing you now. We'll cover that, how to do it. You'll practice it. You'll be able to do it in your sleep just about. We'll talk about figure 8 for clavicle problem, how to do those. We'll do those also. Also for on the hill, anterior, posterior dislocation, doing a blanket roll to get somebody down to first aid for the padding. We'll talk about all of this. Using the splint, we'll do a lot of that. About elbows, wrists, femurs, and so on. Doing different fractures, spinning the hand, all this stuff. It's in your book, but we're going to be doing all this stuff for that Saturday and Sunday. Airplane splints, quick splints. This is what you're going to use, what they'll have in each of the sleds. Getting those on, get them in first aid, taking that off, taking the boot off, and putting the quick splint on. And also how to do the boot removal. And all of this stuff, which I think about ends it, those 75 slides that were covered, we're going to do those a lot. So please be prepared to learn, to practice. There's no one way to do it. You may have a little spin-off on a different way to do something. If it works, fine. There's no right one. There's no one way to do it, but there's only one right way to do it, and that's to stabilize and mobilize. So I appreciate your patience. If you have any questions, again, my email is somewhere, rbyard@satx.rr.com. I've got the phone number 210-415-5958. I plan on being up on the hill on Saturday, the 22nd, at probably 7:30 or 8 o'clock. I would ask that everybody there be there no later than 9, because at 9 we're going to start applying knowledge, not learning stuff, but practicing stuff. So I would ask you, if you're going to be there at 9 o'clock, if that's okay with everybody, on Saturday. I'll be there before that. If you want to come in and shoot the bull or have some coffee, I'll make it early. But we're going to make it a productive 2 days, and I hope you come up, and I'll make it worth your while. Promise.
Hey, Bob, I have a quick question.
Go ahead.
I'm actually TDY, so I'm actually in the East Coast now, but I'm flying back in on the 22nd, so I won't be able to get up there until the evening. Would it be worth it for me to still go up there Saturday evening?
Are you going to be around Sunday?
I'll be around Sunday.
I'll make it worth your while. I planned on being there this Saturday and leaving Sunday, but I'll be there both days. Since I'm going to drive that far, I'm going to be there Saturday and Sunday. So if we get everything covered.
Was it worth it for me to come up Saturday as well, like even though it's only going to be in the evening?
Probably nobody's going to be up there.
Okay, yeah.
But again, if you have any questions, it's 210-415-5958. I'll be up there if you want to give me a call or whatever. But I think we're planning on getting all the upper and lower extremities on for Saturday. And Barney, I think Sunday we're going to do backboard and spine and collars and so on.
What time Sunday?
That's Sunday, yeah.
What time on Sunday morning? 9 again?
What time, Barney?
I'll be there by 8 o'clock, so I only be there from 8 to 11:30. And so we need to cover that, the spine-board stuff, that time. And then if you guys want to work on upper extremity in the afternoon, that's fine. Anything else?
Yeah, we'll get as much as done upper and lower on Saturday, and if there's any bleed over, we can do that in the morning, or if you just want to play some more, we'll do it. But basically, we're going to try. I think we can do 8 to 4, 8 to 4, 8 to 5. There'll be enough time, I think, to get everything covered for upper and lower. But we can reinforce that and kind of fold that into the Barney stuff on Sunday if you want to do it then, or just do some more. But come up for both days, and we'll make both days worthwhile.
All right, sounds awesome.
Anybody got anything else?
No, thank you. Sorry I was a little late.
No problem.
Yeah, we're up in Vail.
I was going to say that's okay, but I'm not going to say that's okay now.
Not anymore, huh?
Are you
now I know where you're at. Now I know where you're at. Where were you? Oh, that's okay.
Kurt, are you skiing?
Yeah, right. There's a little snow up on the peak still. It's amazing. We went rafting yesterday. It was a lot of fun.
I was up in Bend, Oregon for a race about 3 weeks ago, and Mount Bachelor, they're opening it back up because they got so much snow.
Oh, my goodness.
I went up there driving around. I almost ran over a cross-country skier.
Oh, no.
you ever get to Bend, Oregon, you're probably not going to leave. But that's all I got tonight. I'm going to quit. I hope to see everybody on the 22nd. If you come on up, drive careful, and we'll see you then. Barney, thanks for being here. Thank you, Becky. Appreciate it.
Oh, thank you, Bob. You did all the work.
We'll see you all later.
Bye.
Stay safe.
Bye-bye.